thank you. And first of all, thank you again to reference it. Thank you all for making the effort to come in person. I think Charles has got the award for most distance traveled and most time spent in various amber and green countries on his way across. So thank you very much for joining us. And of course, thank you very much for everyone else joining us in person. I'm sure the audience, as much as you guys and as much as we, really appreciate the effort in this sort of the year to get back to networking and deals and in-person meetings. So as referenced, not much to look at on the screen behind, except a sort of bright, pretty image. And if you forget anybody's names, then there you go. It's good for me if I forget any of your names as well. So today we're going to talk about imaging. I think looking at it pre-pandemic levels, the demand was growing about 5 to 10%. You had problems with workforce. It's still a big problem. We'll talk about that today. You've got, backlogs in many countries that were sort of built up due to national lockdowns and everything. This problem's only intensifying. So what we're going to talk about today is just a little bit about how we drive access back into sort of increase access to imaging services and look at technology along with AI and how that is helping us in order to improve diagnosis, to improve efficiency and workflow. So I think to kick off, I'll introduce you. So Nick Webber, most of you know, is the co-founder and CEO of Medneo. Nick, you took your experience working for Siemens for many years and applied it into a slightly different business model. And your business model is at Medneo is to provide radiology as a service.
Correct.
And you're backed by Markel Capital. And you have, 30 centers across Germany, the UK, and Switzerland?
Even more by the end of the year, 40.
40, yeah. Even more by the end of the year. In those markets or in?
In those markets,
in those markets,
so
okay.
the next ones are coming for next year, but for this year, those 3 markets. Yeah.
Okay. Thank you, Nick. And Jan Hornström is the Manager and Director of Imaging at Nordic Healthcare Group Aleris, backed by Triton Partners. You offer imaging services in Sweden, Denmark, and Norway. And in Sweden, you have about a 50% share of the for-profit market there.
Yeah.
And that, prior to joining Aleris, you were with Unilabs,
right,
who is your main competitor in the Swedish market, who occupy the other 50%. So thank you for joining us. Charles Niehaus, he's the chairman of the board at Al-Takasusi Alliance Medical, which is a joint venture in Saudi Arabia, along with the King Faisal Specialist Hospital and Al Jahaz Healthcare. And you're also the chairman of Hexarad, which is a teleradiology reporting business. And prior to that, as many people will know in the room, you were chief medical officer and chief operating officer at Alliance Medical. And thank you, Charles. Thank you again for making your journey. And Stephen Powell is a boutique. You have your own consultancy now, SKP Advisory, but you're a consultant radiologist by background.
Yep.
Is that right? And you up until recently were the chief diagnostic officer at Rutherford Diagnostics.
Correct.
And you were involved in sort of the development of the first clinical diagnostic hub, which came on stream on Monday. Is that right?
That's right. The first
right.
community diagnostic hub, as per the Mike Richards model of community diagnostic hubs. So that opened to patients on Monday, and its official opening is Friday. So
okay.
The Rutherford guys finished that one off without me.
But you're pivotal in the development. So what I think we'll do is just to give everybody opportunity to talk to begin with. I think it would be quite interesting to sort of flip around the various markets and just look at what has been happening in your countries over the last couple of years in terms of impact and how your markets are reacting to increase sort of access to imaging services. So I think, Jan, perhaps we'll start with you and talk about the Nordic markets, because I know obviously with operations there'll be probably quite a crossover in the other markets first. So Jan, what's sort of been the challenges for you and how are you and how are sort of the markets that you're working with trying to address the issue with capacity?
Right. So in the Nordics, and particularly Sweden and Norway, where we have the largest presses, it's a tender market, and the public is divided up in the nation is divided up in regions, and they all decide on when to tender and where to tender and so on. So it's the past years we see more tenders. We see getting closer to the patient with more units, more close to where the demand is, which is one way of increasing accessibility. We also see that the demand for opening hours is widening, and we as a private provider, we are very long opening hours, including weekends, just to increase the accessibility to accommodate the need.
So the government is basically calling out a little bit more for your help.
Yeah, exactly. Yeah.
Okay, thank you. And Nick, I think you're, obviously your UK operations, and perhaps we'll talk about that later. So if you could talk about the issues perhaps in Germany and then also in Switzerland from your experience as well.
Sure. Well, Germany, first of all, is they have an inpatient, outpatient market. In the inpatient, you have a big public sector, but also private, and outpatient is mostly private. And here it's usually not so much about capacity in terms of scanner capacity. It's more about budgets for per examination, so that's limited. But also other things like workforce is a big topic we touch on later. That you don't get qualified staff at all times for all centers. So that is a big impact that we face at the moment, and in certain regions at least. Technology might help to overcome. Touching that topic later on as well. Coming out of this, the thing everyone forgets here in UK, COVID. Here there's still some backlog going on, but backlog is usually not only on the imaging side, it's the whole chain of things. And that's usually not so looked at, that there's a whole sequence. So if patients can't go to the specialist and they can't get referred to a doctor, so the whole chain, or if there's a backlog in for surgeries, then you don't need the image now, but maybe in half a year when the surgery is. And I think this whole chain is still a little bit contrasted and needs some shaking loose.
Okay, but in both the German and Swiss markets, there's been a fair amount of consolidation, and there's sort of a lot of consolidation opportunities.
Well, yes, but the market, well, Germany, first of all, it's still a vast market. And yes, you saw the first wave that there were groups forming, the second wave that PE bought individuals and aggregated them. And now third wave is PE buys groups from other PEs. So first step of acceleration. Nevertheless, there's still vast market out there and a lot of independent radiologists. And at the end, it's very often also about the model young radiologists want to see, with being more women in medicine, more family oriented. And then the question is, do I want to work in a hospital? Do I want to work with a provider? Do I want to be independent but not investing in everything myself? And I think those different models, we need to see what sticks most in that.
Okay, thank you. And so, Charles, just talking a little bit about your experience in Saudi Arabia, sort of coming out of the European context and looking a bit more globally. I mean, talk us through that and some of the issues there. It's a very different market.
Yeah, I think the issues are probably the opportunities there.
Okay.
I think the European market's very well developed from a public service perspective. Then you go into the emerging markets where the governments tend to try and provide solutions for the people, but the capacity is not necessarily available. And that is the real challenge, but also the opportunity if we really believe in benchmarking of scans per million of population, which means access to people to have proper healthcare, in this context, imaging. And then you get the US on the other side that's got a very private-driven market, lots of capacity, etc. So Saudi Arabia, we've got a unique joint venture with Alliance Medical, King Faisal Specialist Hospital as the regional clinical lead, etc. And then some private equity investors in there with Nexus. We are delighted to create a platform. I think this is where the issues come in.
Yeah.
I think things take a lot of time in the Middle East. A lot of people have been there and have left. But the fact of the 2030 vision by the kingdom is absolutely well spelled out. It is moving into the right direction. There's outsourcing of all the radiology facilities there from the government perspective. And why would they do that? I think outsourcing is seen in the public sector in Europe sometimes as a bad thing. But I think where it gets to an emerging market, a place like Saudi Arabia, where you've got the ability to provide access for people that haven't had access before. And it's not necessarily, when we talk about capacity, an infrastructure challenge or a technology challenge or a resource challenge. It's a combination of all of those. And I'm sometimes stunned at the amounts spent by governments per head of or per examination, if you really come back to the fee-for-service model. So I think that's a real opportunity both for the government to provide cost-effective, good quality care, and then secondly, for patients, because I think with the same pot of money, you can treat 3 or 4 times the amount of patients that you do at the moment. So I think, where outsourcing is seen sometimes as a challenge, I think in this case, it could be a real solution, bringing together local partners with international expertise, like people like Alliance, with a combination of things to provide a solution to the region. So I'm very interested and very excited about the opportunity.
I mean, we touched upon that a little bit in this morning in Rachel's session. We kicked off talking about building international platforms, and one of the things, and having lived in Saudi Arabia myself for a few years, I kind of know the cultural issues that there are there in terms of, there's a sort of a culture of brand. And Rachel said, we're talking about how important foreign brands are. I think Frederick Radmark said, in Medicover when they went to India, they needed a Western brand. A local brand wasn't seen as acceptable. And I know that in Saudi Arabia, it's all about brands. Aramco wouldn't hire anybody unless they were McKinsey, because they were seen as the top consultants. So, how, with that in mind, do you see that as a huge future opportunity in your discussions? That is the kingdom looking to develop their own workforce? Obviously, they've got their own sort of requirements and that.
I think as a clinician, and you're always stuck with a situation where there's great clinical people everywhere in the world, but they need the opportunity and the platform to actually evolve and develop the services. And there's a good saying where the grass is not always greener on the other side. And I think that's the case for a lot of the emerging markets, where clinicians are looking for international support to evolve and develop their practice, rather than just bring in international practice. I think, if you compare South African healthcare with European healthcare, you learn a lot about governance in South Africa, but in Europe, whereas in South Africa, if you go there, you learn a lot about practical experience and a total different disease profile. So I think the opportunity here is that you actually want to bring those things together and create a platform supported by international best practice, where you actually provide a world-class service, where you can benchmark yourself with other regions in not only the Gulf but beyond, and likewise for Europe. We compare scans per million on a daily basis between Sweden, Germany, and there are variation. But that variation, we need to understand what it is. Is it a commissioning issue? Is it a funding issue? Is it a resource issue? And I think we're going to touch on some of those issues. But they're all real, right?
Definitely. So thank you, Charles. So Steve, we talked about capacity in the UK context. It'd be quite interesting to just go through the sort of the UK's approach and the plan for community diagnostic hubs.
Sure. If we start with where we are in capacity today, we're the poor man of Europe. We're dreadful. The data that Mike Richards has used, while historical, is actually still accurate, because there hasn't been an investment in equipment in the UK, apart from the independent sector, and that's typically supported by short-term contracts. So it's mobile solutions, temporary solutions, relocatables, not the static facilities that perhaps we'd all like to provide. The idea of community diagnostic hubs, I guess, comes from 2 elements. One, we've got confined infrastructure in hospitals, so we can't just keep adding scanners as we need them. And hospitals are landlocked. We have a PFI system in the UK, which means we can't easily go outside of our boundaries either. And then we've got COVID, and we found that the way we designed hospitals as an outpatient, it was very difficult to suddenly access services, because we had red areas, amber areas, and we'd have to cross those to get to a green area like outpatient radiology. So we need a second front door, and we need to separate elective and non-elective activity. I've been banging this drum now since I was a clinician, as you well know. And we talked about, why is outsourcing the right model? And all I can say is that trying to do it on the inside was impossible. It took leaving, raising the capital, finding the resources, whether they're personnel or just simply capital, to make the project happen down in Somerset, where the guys are working today. But it also took a very ambitious NHS trust to work alongside us in a way that typically you don't find. So stretching the procurement rules, extending the contract length, making the investment work, all of that is very, very challenging. And then to provide that as a value for money offering That's business model innovation. That's kind of clever stuff. It takes quite a lot of input and frankly, years of work to get there. When we spoke about this, it must be 7 years ago, and that's how long it's taken for us to get to the first CDH.
Yeah.
So the plan now is to create that second front door, to have up to 150 of these centres. I suspect that's over-ambitious. We probably won't get there. But if we can get to maybe 30 or so, or 50 key geographical locations scattered around England, I think that will improve the diagnostic performance of healthcare here in the UK. And remember that if we can get diagnosis early, then we change all of the other socioeconomic impacts of having poor health outcomes, late-stage diagnosis, ITU stays, complex surgery, becoming an economic burden because you can't work anymore because you've got the burden of extensive disease. So we have to invest in diagnostics to really change health outcomes in the UK.
And one of the big issues you touched upon is the length of contracts, right? So presumably the CDH, just to clarify, it's 150 sites in 3 years. Is that the ambition? That's what I read, which seemed very ambitious.
That's the very big ambition.
Okay. Yeah. And the contract length is what, 3 years with a sort of a look at review in 2?
Yeah. So
total?
I mean, that doesn't really work, does it? So I don't suppose I can get any of you to invest in a £20 million building with scanners and equipment and offer you a 3-year contract, because you can't amortize that investment over that period.
Without committed volumes, by the way.
Yeah. So the current thinking, let's turn back to Jeremy Hunt last night. So we talked about the fact that local decision-making is best. But local, and it is in a way, but it's also bound by procurement rules.
Sure.
So the procurement local expert will look in his book of rules and it'll say 3 years plus 2 years is a standard NHS contract. So that's what we can offer. We have to think differently if we're going to do a real scale national infrastructure project like this and start looking at 10, 15, 20, even 30-year contracts to make, you were the beneficiary of a government contract, the national PET-CT contract here in the UK, and that was 10 years. But imagine if it was 30, you probably would have put in hot labs next to your PET scanners, you would have been doing novel isotopes. If we're going to grow up in healthcare, we've got to just extend beyond this sort of risk aversion 3+2 style contract.
I'm going to put my foot in it a bit maybe and just
Go
say
for
I
it,
think we've got to
please.
extend beyond the political period. 3+2 seems to meet the needs of politicians, but if you're really in a clinical environment and you want to make investment that is required in healthcare, not only in the infrastructure building, the technology, workforce is a huge resource issue in this country, as it is globally. I mean, it's every country in the world's got that challenge. Just to train people up for 3+2 contract does not work.
Yep.
And, the transition of it, and I think people are accepting more the public-private partnership as long as you get that local buy-in and you can develop it. We give PFI contractors 35, and then it's not affordable, 45-year contracts in the UK, and indeed in Saudi it's the same. Theoretically, we should, if we really want a good service and we've chosen a provider, invest that same amount of time in it. You can't invest in a proper cross-sectional technology, upgradable, imaging equipment that's depreciated over 10 years in most financial systems in a 3+2 contract. And there's a way of taking the risk. If you don't perform, by all means, I believe the government needs to have the right to step in.
Sure.
But the resource challenge is not only in the private sector; it's in the government sector as well.
Yeah.
And I think innovation is sometimes stifled by that because we need to try and come up with the same solutions rather than bring some innovation to it.
Thank you. And I mean, so Jan, you've obviously experienced this, in the markets, in your home market in particular. I mean, how successful have you been? I mean, how have you been successful in extending those
I think
how do you do it?
Yeah, it used to be a problem with really short contracts, especially some countries. But now I think we've managed to push them a little bit. So now we see 4 or 5 years +2. And the good news for us is that they are really, really poor at retendering. So they tend to prolong even beyond the due date. So in the end, it's okay. But
So it's the assumption that we'll sign it, but they're not going to kick us out.
Yeah.
They're not going to find a replacement for this contract.
yeah,
And so far, that's been a successful.
I think we're average around 7 years now in the big contracts, which is doable.
And renewal rates, is that how it works? Do you track renewal rates? Are you able to renew those contracts quite easily?
Yeah, well, I mean, there are several providers bidding, of course, but
Sure.
but it's a nice balance that we have now up in the Nordics. We're quite mature market from that perspective.
And Nika, just before we move on maybe to a slightly different topic, let's talk about technology and then prepare your questions. I want to open up to the floor. I'm sure all of you are sort of itching to ask things. So, I mean, Nick, in the UK, obviously, we haven't touched upon that market for you. I mean, how, with your model being very different, how do you see an opportunity? Do you see a threat in terms of the CDH plan? What's your perspective?
Well, for the UK, we don't see a threat at all. I mean, also the CDH need to get going now with the volumes, and they won't do build everything from scratch in a few months. So they still need good services on top. And very often, again, it's not only about building infrastructure capacity; it's everything, the whole system around. It's the technology, it's the workforce, and bringing that to a high level that you have a real clinical output and a real quality, not only get waiting lists down that you can tick the boxes. And here that's clearly the thing we are focusing in to be efficient, but in the high quality segment. And so far that's working very well with us to actually partner with then those the trusts also in future, hopefully the CDHs to get going. So there's a long period that needs to be filled and supported in the whole system, and that's actually quite good. But on the other side, when talking about the strict contract lengths, in Germany sometimes you have quite the opposite. So you don't have clear rules. It's all individual negotiation, but it takes forever, this individual negotiation with everyone. So because everyone needs to have a buy-in in that, not only the CEO of the clinic, but also the facility manager and the technician and whoever else. And you end up with funny discussions that take 2 years without anything getting done. So that's not much better than having rules that you not all like. So.
I think moving on slightly, and I know we've got sort of a number of OEMs or original equipment manufacturers in the room, and one of the biggest issues for both parties is utilization, right? And I wanted to touch upon technology as a whole and just starting there and just thinking about what are some of the issues and how can the OEMs or how are the OEMs working with you to help improve that? And I know, Charles, you sort of had particular opinions on this, right? So perhaps we'll start with you on that.
Yeah, I think it comes back to the point about utilization, right? It's expensive assets. If you can run them 24 hours a day, you can bring the overall cost down for everybody. But people don't want to come at night. You know, in my previous career, we started earlier in the morning and we started Saturdays and Sundays in the beginning. Everybody said they won't come, and yet they came. So I think that's, you spoke about extended hours, and all of those things are having an impact on it. And in order to do that, you've got to really work with the equipment manufacturers in order to ensure uptime. That's such an important component. If you think about your one examination a day that you're going for, once a year or twice a year, you've got a possible cancer scare. You arrive there and the equipment's not working. The cancellation and the booking, forward booking, it's full for 6 to 8 days, is a real challenge for every patient. So, I think working with our OEMs, we've worked, and I know all the providers work very hard to ensure that uptime for the patient, because that is absolutely one of the first critical things that can stop a backlog from happening. I think the other aspects is new technology, and I think it's fascinating to see the newer technology that's come up in the market, quicker scanning sequences, moving patients, removal of dockable tables, etc. All of those things cost money, and I think in the previous session they spoke about, if you're actually investing that money to get a better throughput, why must the provider always absorb this efficiency? because it needs to be absorbed in the public health system as well. I'm a firm believer that the public sector, or the private sector's got the ability to help lead the public sector into adopting new technology, adopting innovation. We've seen it in PET-CT in the UK, where the public sector started, and then the private sector started and the public sector followed. And I think that's the key. You won't get that innovation if you don't allow those practices to happen. So working with the OEMs is key. But I think, I think all four of us have said it. It is about the resources. The training of radiographers and radiologists is a key issue. The infrastructure, the technology that fits into that. And the previous session was very interesting, looking at Austria, where they've got a universal electronic patient record. I think that is key, to learn from. Everybody talks about big data, but big data in COVID didn't really teach us a lot. It just helped us to be more confused. And if we had all the data of all the patients that had COVID in a uniform data set, I'm sure we would have had better assumptions that we could have made in the prediction of patients falling ill, etc. So I think there's lots of new things that needs to happen in the utilization of imaging as a whole, as part of the wider pathways. You said.
I think for the OEMs, as I said, uptime is definitely key, and innovation, so that's their home turf. Everything else, commercials, having the whole process, there's not much help you can expect. They all try to have different kind of models and make tiny steps in that direction, but it's not really covering any risk or something that really would help us also in an environment where you have a 3+2 contract that limits your risk. So that's clearly not there, because they stay away from that as well. So I think if everyone focuses on what they can contribute, then that's a good thing.
Yeah.
I think the OEMs have, for a long time, designed, step change in equipment performance. And okay, we've seen a much faster MR scanner recently, which is a good thing because you can be more efficient. But in reality, the solution that they've been coming up with is how to look inside you and tell whether you've got disease or not disease. And actually, that question is now answered. I was talking to the guys at GE last night, and they're talking about pivoting their entire business model to operating end-to-end service solutions with partners, with collaborators, with NHS partners also. Because the problem today, if you go and see a clinician and say, I'll give you a free machine, they'll say, why would you do that? That's going to create a headache. I've got no one to staff it. I don't want to do the reporting. I've got enough reporting to do. Who's going to operate it? Where's it going to go? They're the answers that the service today needs. That our NHS needs those sort of answers from us, from OEMs, not from, they're scratching their heads. They don't know where to go. They're landlocked. They need somebody to acquire some land, build them a clinic, put the equipment in place, work out how the hell we're going to staff it, where's the reporting going, and how are we going to grow those staff long term. That's the solution that we need to be providing today.
Yep.
I mean, Nick, just on thinking about technology, you referenced a partnership where you're working with an insurer and you're working with, is it the Berlin Heart Center, and you're working on a new cardiology project. I mean, just talk us through that a little bit more about some of the opportunities that technology is enabling you to do with diagnosis.
Well, it's actually twofold. That's a technology element, and that has also a more how to apply services to groups that didn't have access to it before. So which is always dear to our heart. So that's why Medneo started in the first place, to give access to patients. And what we're doing here is to have a specific group of patients with and provide them with a heart scan, also public insured patients that are usually not getting screening examinations in that, working together with a health insurance company who is identifying the patients and providing those, working together with the German Heart Center from a medical field, and us providing the imaging part of it to do that also in remote areas with mobiles, but always with this high quality aspect. Very often remote remote supported, that radiographers, some radiographers in remote regions, it's really difficult to get them there. So you have a radiographer who can handle the risk, who can handle the patient, but not necessarily knows all the buttons to press. And that's something you can support remotely with technology, that you can remote guide the scanner, or also have training concepts then along the way to help the person who knows only half of it and gets educated over time. So it's like a co-pilot, or the real pilot for the co-pilot that way. Do the reading also completely independent from local doctors, and bring that to experts. And so here technology and access to services, and also payers who actually want to provide that service is really key. And ideally, on a long term, we create also reimbursement numbers for public insured patients, that they get this service in future if you can demonstrate that there's a real value behind it. So that's the whole sequence of it, and a lot of puzzle pieces need to get together. And I think that's the real challenge in healthcare. So everyone seems to work in silos in the past, and how to bring different people together with different mindsets, and that's not easy. I mean, it sounds so great sitting on a stage and talking about the collaboration, but that they are completely different cultures, completely different people. Even if one partner like the health insurance is responsible for identifying patients, but they've been on holiday, and they've been there was COVID, and I couldn't manage, and we are there ready to go, and said, well, we're waiting for you now. So those are the things that need to happen more often, but they need to be also managed. And I think this management capacity, and that's probably my last statement to that, this management capacity is really something we are lacking in, I think in most markets.
The management capacity from trained managers inside, or from?
Well, actually, for all those collaborations and those partners, that needs to have a strict management, and also within their team, so to prioritize those things, to really see to get stuff done, and not say, well, I'm like a public employee, and I get my salary anyway. So to have a different mindset, and that's something we need to celebrate a few successes to get this team spirit going, and I think that's still a long way in many projects.
Yeah, go ahead.
But I think that is where workflow engines and stuff like that is actually taking the administrative burden away from the clinician to actually do what they want to do.
That is true.
Specifically around teleradiology solutions, allocating the workflow, taking that administrative burden away from the clinician. Actually, what clinicians want to do is they want to report, they want to help patients make diagnosis, etc. And indeed, teleradiology. We talk a lot about telehealth, and I've got a different view on that. But I think teleradiology is the one aspect where, with a proper referral, historic imaging, and a proper imaging data set from the scans, you as a clinician can actually make a diagnosis quite effectively and help the patient. I think a lot of the other things is still in the making, and I think wearable devices, etc. But that is where teleradiology is probably at the forefront of a lot of these things. As long as you have the local involvement, the local integration there, and I think my other big issue that I think over the years is a challenge is not information governance, because that's quite well spelled out in the law. But the fact that every law firm has a different interpretation thereof, and every trust has a different interpretation of it, is actually stopping innovation. Yeah. It's stopping the patient care pathway and patient records getting back freely. So I think there are things that we could do to actually help technology help us do things better.
Yeah. I mean, just picking up on that teleradiology, and I'll ask this and then I'll open up the floor to some questions. Jan, in terms of that, I mean, the workforce issues that we have, I mean, there's some criticisms that teleradiology perhaps is adding to the workforce issues by, saying, well, why don't you go live by the sea instead of in the middle of a landlocked environment?
Right.
What are your sort of thoughts on that? And
I mean, exactly, because teleradiology is by definition you're just reporting remotely, right? So you're not really adding a resource. So if you take, like we have in the Nordics, we have Swedish radiologists. They go to sit in a nice building in Barcelona to report for Sweden. It's the same radiologists. They just moved the radiologists. So to a certain degree, it's not really adding capacity. It's not helping with the resources that we need since we have a scarcity of radiologists. But on the other hand, there are a lot of situations where it's very adding a lot of value. We have been using internally in our organization teleradiology for many, many years just to balance the peaks where we need them. And of course, if your doctor is going on holiday or sick leave or training or conference, you need to replace that with someone. And teleradiology is a great tool for that. Not to mention all the on-call needs in acute care hospitals at night, for example. So there are many areas where it really adds value, for sure.
Thank you. I mean, does anybody have any questions? We've got about 10 or 12 minutes left. No.
While we're waiting for a question, can I pick
Sure.
up
Yeah,
on
please. Sorry. Go ahead.
artificial intelligence?
Okay. I was going to
So-
come to that at the end.
so
because
we-
it's a big topic.
It's been talked about repeatedly in the conference, and it's always applied to the sort of, I'm going to use the wrong words, but the high-end element, the reporting of studies, which is really, really complicated. And actually, we need to talk about radiographers and how much of a scarce resource you've already alluded to they are. We heard yesterday that AI is there to replace the mundane tasks and allow us to be much more productive and much more creative in how we work. And actually, there are tons of mundane tasks that radiographers do. Positioning the patient in the scanner. Well, my phone can recognize my anatomy, so the scanner can, and it can self-position. You know, that technology is coming, okay, so that's fine. But picking up the sequences that the radiologist wants, that can be automated. Lining up the slices on the MR scanner at the right axial or the right sagittal, systems must be able to recognize this and do it themselves. You know, we need to unburden radiographers. I love Yuval Harari's Homo Deus.
Okay.
We need a new genus of radiographers, radiographer deus, where they're godlike and in charge of multiple systems all working at once. And that's, I think, where AI should be focusing at the moment, because the reporting is great, and measuring lung nodules and auto-segmenting aortas, that's quite a phrase. It's all very well, but it's not the complete reporting package. So you still need a radiologist to fully read the scan. It's there as a check or a guide, but actually solving the workforce problem by automating some of those more simplistic tasks that radiographers do, I think that's where people should be investing.
Well, as much as I like the idea, and it clearly will be the future, but there are so many steps in between that that we can already and should already do today. Well, we first start with to digitalize the whole workflow. Not there yet. So if you don't have that, you don't need to talk about machine learning, AI, or whatever. So and that's the thing we are still at. So in many countries, so in Germany, for instance, gold standard is still that the patient gets a DVD and the report is sent via fax. I don't know where to put my DVD anymore, so my computer doesn't have a slot. So, and those other things, and there's so many layers that you can provide then for the professionals, adding additional applications and services like that you have post-processing software and so on demand if you need it. Doesn't even need to be super AI whatever, but adding those tools in a highly comfortable, easy to use way, not in a complicated one where I need to do 3 turnarounds to actually do that. And there's so much for providers, for clinicians, for radiographers, for patients especially, that we can do before the algorithms are taking over. So I'm not against. I am super much in favor, and as much as I like to have that, but I think there's a lot of homework we can already start doing today.
McKinsey and the European Institute for Innovation and Technology, I think it's last year, brought out a report on AI. And I think if we really go look a year later, nothing has changed. And I think, I think investing in AI, in addition to the stuff we said, which is actually just business processes and workflow management, which is available. If a manager doesn't even have a dashboard where they can say, well, this is how I'm going to manage my capacity forecast for the next 7 days. That's basic stuff that we need to do that will affect patient care before we start looking at the algorithms. And I haven't seen an algorithm that's going to give a return on investment of some of the things that's happening in the market at the moment, in my opinion. For now. And I'm not a radiologist, but I think it'll take time. And I think there's a lot we can do with patients, investing money up behind that to affect our efficiencies.
Yeah. And because there's been obviously a huge hype in so that you've seen lots of AI startups, lots of capital raised, particularly over the last couple of years. And do you think, I mean, is it true that some people are sort of looking to that and ignoring the management processes and the simple things? Or is it,
I think at the moment, very often it's an excuse not to look at the stuff you can already do today. And again, I'm all in for AI and algorithms and what you can do with that. But I'm also suggesting let's start with the things we already have today from a provider side. From a startup side, I think there's a clear investment case for investing in those kind of algorithms and ideas, but you need to see where to start and how to apply them. And then the next thing is how do you actually utilize them? They are not reimbursed in most of the systems. Usually you have a budget restriction. You can't get additional top line elements of that. Bottom line, well, it's first of all the cost. You probably the companies want to have a business model for that as well. Then the question is how much workforce can you save? And on a macro level, probably you can save a lot if you do that for a country or for a bigger group. On an individual level, and a lot of medicine is still done in a single hospital, in a single practice. There's not much. If you have 3 radiologists, you can't reduce one because you need Christmas and New Year's Eve and whatever people there. And that's the challenge. On macro level, that all sounds so easy, but applying it in reality, that's the real challenge.
That's good. You must have read the question. I was going to come to that in a second. So we had a question from Martin Kodar, and are you in the room, Martin?
Very much so.
It is exactly that. So you've kind of answered it. Do you see that AI will be reducing the workload of radiologists in the near future? So you've answered a little bit. I mean, Jan, what's your thoughts on that?
Yeah. So we've been trying out, validating, and we're actually using a couple of AI applications clinically today. Are we reducing workload? Not really. The doctors, they feel more comfortable with this AI tool. Is it really adding quality to their report? Not really. I mean, they would have probably given the same report without the AI tool.
Okay.
And then we have the financial aspect, because we see that the developers are still trying a little bit different financial models, but they want to charge somehow. And at least in the Nordics, we don't have a reimbursement code for using AI like they used to be for CAD systems, mammography in the US in 10 years ago. So we have to finance the use by actually making savings somehow. And from that perspective, we're quite far away from that so far. But I do think we're going to get there.
But you in particular in your markets, you're talking about second readings, right? And where that is an efficiency saving for you.
Yeah, I also see it like you mentioned in the radiographer process. We are having some discussions in some of those areas as well. So both for radiologists, the workload, but also radiographer and the whole process. Yeah.
Charles, do you want to pick up?
I sometimes think there's aspects where AI can actually play a role in terms of identifying things that the clinician will not be reporting on. And if you look at that, there's some new investments in that, where they're actually trying to find answers that's not part of the clinical report. And that becomes a value add, in terms of things, adding it all together, producing a report with the historic information. But it's, I've not seen pure AI going to replace a radiologist, because I cannot see how they're ever going to get past the indemnity for that clinical report that needs to be signed off.
Sure.
So it's not because I think we're all service providers that we're sitting here. I think it's just the challenges that we face with clinicians wanting, or scientists trying to implement AI into a place where in that tariff envelope, there is nothing for it. So we really got to find where it adds value to it.
But if you remember some 10 years ago when we had low dose softwares, image rendering, and there used to be a third-party provider sitting in between the modality and the RISPAC system. And there was a lot of controversial discussions. Okay, so who's responsible if there is something wrong in this image? That's not an issue today.
No.
It's all embedded in
Yeah.
the modality, right? So I foresee that some AI applications will actually just become embedded in the modalities or recent pack systems and to be used by us.
I would agree on that. Yeah. You mean you have self-driving cars now on the road, and that's the same question behind, and it will take an even longer time in healthcare for all the good reasons we know. Nevertheless, it will eventually come. I'm very convinced about that.
I was sitting with a radiologist recently, and he was reporting a TAVI scan, so looking at the thoracic aorta and for a valve replacement. And you would typically measure the aortic root at various places and the distance to all the various branches that come off. It takes forever to do. But, technology's moved on, and the guy clicked roughly in the middle of the aorta 3 times, and auto segmentation happened. And he said, why do they need me to click? At some point, they're going to realize the lump of carbon can go. And we heard yesterday, when it gets adopted, it's no longer called AI. Right? We just forget it's just part of the PACS system.
That was a good one, yeah.
Part of the technology that we're using. So I think it will get adopted. I think it will lighten the load. I don't think we're going to replace radiologists quite yet. I'd agree with Charles.
I mean, sort of thinking back to your career, I know it's very different with video. If this was when you started, when you were training, and versus now, I mean, you wouldn't be scared. You wouldn't be scared of AI replacing your job, surely. I mean, the benefit is that you'll just be able to specialize in something.
I hope AI does replace radiologists, then I'm justified in making the move away from a career in medicine. But look, I'm old. When I started working, we did angiograms with puck changers that would fire films into the machine at rapid speed, and then we got flat plate detectors, and we got wonderful scanners. Technology has advanced massively. I mean, when I started my career and when I left, the two things were just wildly different.
Yeah.
And maybe, I mean, there's a second part to that question. We've got about a minute left, and the second part to that question, if we whip round, is what type of imaging will be the first to have AI do the reading? And I guess that you've said it probably won't be any. Is that true, or is there a type where you can see that it'd be?
I think there are some areas which is perhaps a bit easier, like MRI prostate, where you have defined different outcomes of diagnosis, where it might even be better to have an objective AI judgment than a subjective doctor. And we are trying that one out.
But there's systems for lung nodules, kidney lesions, liver lesions. There's systems for the pancreas, the chest X-ray. The problem is they're all being developed in isolation. And I do hope that people have got the sense to write that code in a way that they can start to work together rather than being completely isolated systems, because then product adoption will be impossible.
And that's where the technology angle comes to bring those sort of clinical diagnosis teams into central sort of point of review, right? And that's where the future is. Well, it looks like we're out of time, but thank you very much, gentlemen, for that, and thank you everybody in the audience for coming. So,
Thank you.
Thank you, Lee.
Thank you.